Well, in this short presentation, I'll cover developments in terms of ultrasound technology that over the last 5-10 years has had an impact in terms of fertility studies, fertility managements, investigation of recurrent miscarriage, and also assessment of early pregnancies, mainly pregnancies that have resulted from those clinical programs. So in terms of those technologies, I think what we want to highlight here is, first of all, we're not always aware of it, but the vast improvement in terms of grayscale imaging that has occurred over recent years. And by improvements in grayscale, I mean improvements in terms of sensitivity, contrast, spatial resolution, not cosmetic exercises. 3D has played an important part in terms of what we're talking about. And in particular, I want to talk about color Doppler. And I think color Doppler has been certainly undervalued. And it's very, very important to us in all of those elements that I described. So we can start off with this standard image that we're all familiar with. But really what we're going to emphasize, first of all, is how ultrasound can now show us how the follicle, the ovarian follicle, which is an organ in itself, develops. And it allows us, modern ultrasound allows us to gauge the activity of that particular organ, and in particular, its effect on the endometrium. And we're not just talking about the ovulatory cycle here. Remember that if we look at symptomatic patients coming through our gynae clinics, then 70–80% of those patients actually have functional issues. And those functional issues are really atypical processes within the reproductive cycle. So we'll start off by looking at the ovary itself. And you can see that with modern 2D, with modern 3D rendering, we can get quite detailed images of the ovarian morphology, whether we're looking at a developing follicle here, whether we're looking at atritic antral follicles. There's a persistent corpus luteum there from the previous cycle. So we're now able to look at ovarian morphology in some detail. But before we get on to the actual activity of the follicle, pre-ovulation and post-ovulation, just some kind of an interesting diagram here. This diagram has really resulted from our use of 3D over the last 10 years. And it's an interesting diagram because you can see it's over 10,000 patients. And we've scanned these patients, I suppose the equivalent, to take this textbook 28-day cycle, the equivalent of, say, around day 8, day 10, kind of mid-proliferative phase. And you can see how 3D has shown us how the general morphology of the ovary changes with age and with parity. And I think the 3 points that we would emphasize here as a result of this study is, first of all, we have to be very, very careful in terms of our diagnosis of PCO from an ultrasound, because you can see here that certainly with teenagers, women before they have pregnancy, the ovaries are naturally multifollicular. And the next point I would make is remember that we have this thing about antral follicle counts and telling women in the 40s that they're subfertile. In fact, they're not. There'll be tens of thousands of women conceiving naturally in the 40s, and they still produce nice follicles. The third point I would make is that the most common cause of postmenopausal bleeding is breakthrough ovarian activity. So I think it's very important that before we get in a little more detail about the ovarian anatomy and physiology, just to kind of realize the changes that occur with their age and parity. And that is very much, what 3D has given us over the last 10 years. And these are just examples to show how the ovary moves from this kind of multifollicular appearance to less follicles, to our kind of young lady in her mid-40s, still fertile, less follicles, but still a very active ovary. So we'll move on now to the follicles themselves. And we're dealing, first of all, with the preovulatory follicle, and then we'll talk a little bit about the corpus luteum. If we go to the preovulatory follicle first, I think the first point that we would make is that follicle size does not necessarily reflect the maturity of that follicle and the maturity of the egg and the successful outcome of a fertility program. We have to look, from an ultrasound point of view, we have to look at parameters that gives us more information from that point of view. So if we just kind of continue concentrating on the preovulatory follicle, this is a study we did about 12 years ago. We presented it to both BEMIS and ESRI conferences. We took 100 patients, and basically we looked at the preovulatory follicle, and we measured estradiol levels and compared them with our ultrasound parameters. So there's the inference chart that we arrived at. And I suppose the statisticians might say that it looks like there's a good correlation there between follicle size and estradiol levels along the baseline there. But if you look at it more closely, and if we look at follicles, say, of 2 centimeters, and follicles of 1.85 centimeters, you can see that there's a tremendous range in terms of estradiol levels if we look at those particular measurements. And so that kind of emphasizes the limitation of just looking at follicle size. Now, it particularly applies to assisted conception, IVF in particular. IVF underuses ultrasound. And if you have 10 follicles with an estradiol level of 1,500, 2,000, you don't know whether that 2,000 is spread across the 10 follicles. You don't know whether just 1 or 2 of those follicles are producing that level of hormone. So therefore, we need something extra in terms of gauging follicle activity. So if we now introduce color Doppler, and we look at the peripheral angiogenesis associated with a developing follicle, and we use this, this is quite old material now, but just kind of roughly gauging the peripheral vascularity around that follicle, then this is the inference chart that we get. And you can then see how we get far more accurate information in terms of the maturity of a follicle if we look at the vascularity of the follicle, not the size, but the vascularity of the follicle. And we have other parameters, other ultrasound parameters to help us in terms of assessing follicle maturity, whether it's a natural cycle, whether it's ART, assisted conception. This is what a follicle should actually look like around ovulation. This patient is in the process of ovulating, about to ovulate. You can see the irregularity in the wall of the follicle. You can see the separation of the wall. You can see the peripheral vascularity. So color Doppler gives us that information, but also we can look at the endometrium. The endometrium is the end organ in terms of estrogen production, the effect of estrogens. Also, we've shown in the past that with modern transvaginal scanning, and particularly with fly-through, we feel that we're able to see the cumulus mass, particularly in cycles where we've stimulated the ovaries and we've used a trigger injection. So what we're saying here is that just measuring follicles, so it's not good enough in terms of assessing an ovulatory cycle, whether it's a natural cycle, whether it's assisted conception. If we then go to the other side of ovulation and we look at the luteal phase, again we did a similar study, separate times, 2 years apart, and here we were looking at the corpus luteum, and we were looking at the vascularity of the corpus luteum, and we used this kind of very crude kind of grading system there, again kind of reflecting the vascularity, peripheral vascularity of the corpus luteum. And you can see first of all there is kind of a correlation between increasing vascularity of the corpus luteum and increasing levels of serum progesterone. And then if we kind of bring in the endometrial appearances to that study, and if we take kind of the white dots as a receding endometrium and the red dots as what we'd regard as proliferative endometrium, and the triangles with the pregnancies, then you can see how color Doppler shows you the essential activity of a corpus luteum in terms of maintaining a pregnancy, producing a nice lining. So if we take one step further and we actually look at pregnancy itself, here's a patient just over 3 weeks from ovulation. So that's just a matter of looking at heartbeat, particularly in that high-risk group that I've described. We have to look at the ovary. And if we look at the ovary, what we want to see is good peripheral vascularity. And certainly the clinical team that I work with, if we take this example here, where we have an intact, thick endometrium, this is really kind of on the day of the positive pregnancy test, 13 days after ovulation. We look at the ovary here, then obviously there's a clot-filled corpus luteum there, which obviously difficult to see on the grayscale, but there's poor peripheral vascularity. So we would give that patient progesterone. And this is that patient a few weeks later. So, you know, what we're emphasizing here is the use of color Doppler in terms of assessing pre-ovulation and post-ovulation processes. So we can take that more into pregnancy. So this is, again, very early pregnancy and an active corpus luteum. But we're now moving from the effect of the ovary onto the endometrium. Now, if we look at the endometrium, the ultrasound characteristics that we're looking at reflects glandular activity. There is no such thing as triple layer, that kind of thing. The ovary is an organ, the endometrium is an organ in itself. And what we're looking at here is the endometrial stroma. It's the stroma that we're interested really at any stage of the cycle. And we know that as we go through the ovulatory cycle, the endometrium changes. And as I said, it reflects the glandular activity. So here's our kind of mid-proliferative endometrium. The endometrial stroma is not anechoic. There should always be echoes there because there is tissue there. There is tissue there. We have to move away from this triple layer thing that the IVF world has suddenly introduced. It's disrespectful to the quality of grayscale imaging. If we move on to periovulatory changes, you can see how the endometrium is filling in. is because of the glandular activity. And we go to our post-ovulation, and this is a conception cycle. These are the characteristic endometrial appearances that our quality grayscale should now be showing us. And conversely, you know, staying with the luteal phase, also we can pick up shedding of the endometrium at a very, very early stage. And we can also pick that up on elastography. So this is the kind of detail that we want from the endometrium. And we've certainly reached the stage now where we can really look at the glandular development of the endometrium in detail. This is kind of the stage we've now reached in terms of our ovulatory assessments. And you can see that we can not only visualize the individual glands as they grow from the basal region towards the superficial layers, we can also now identify the spiral arteries that are supplying those developing, proliferating glands. And this isn't just kind of a fertility issue. You know, if we recognize these changes, we can recognize estrogen dominance in terms of perimenopausal patients, for instance. If we recognize normal vascular pattern, we can therefore recognize atypical changes, say, associated with endometrial cancer at the very, very early stage. It's the vascular changes that we can now pick up that allow us to identify these changes very early on. So we can continue that into the pregnancy itself. And this is a highly magnified image of early pregnancy there. You can see the trophoblastic response very, very nicely. Again, an organ we can now look at, an organ we're very dismissive of. Remember that the trophoblast, that's important in terms of transferring nutrition through to the pregnancy. It's important in terms of the implantation process. It's important in terms of developing the placenta. But we ignore it. We never look at it. But we should always be looking for a uniform trophoblastic response and differential development as the placenta develops. But the significance here is, if we look at the decidua, again, with our rendered image, we can appreciate this glandular proliferation, which is crucial towards as far as early pregnancy is concerned. So if we, as monitoring a patient, the patient comes along and there's an 11 millimeter endometrium, that doesn't necessarily tell us it's a good endometrium. 11 millimeters, we should be seeing more glandular activity than we're seeing there. So, you know, this is kind of this is very detailed observation. And I think it kind of emphasizes how the world of IVF in particular are missing out because they do not look at the endometrium. I don't know of any IVF unit that looks at the endometrium after egg collection. I gave a lecture in Dubai on the luteal phase assessment in IVF pregnancies. Had nothing to say because IVF don't look at the luteal phase. But you can see how important it is in terms of assessing the endometrium, and also to emphasize that if we look at the endometrium, we're no longer involved with thickness. We want to see textural changes, the glandular changes. We want to see good delineation between the endometrial and myometrium. Obviously, you think in terms of adenomyosis, this kind of, or cancer, these kind of pathologies, that's important. And again, you can see there the importance of looking at vascularity. And you've also seen an example where elastography, compressibility, was of value to us. So if we now move on to early pregnancy, okay, we can pick up pregnancies fairly early on. You've seen that already. But to emphasize that if we're going to look at an early pregnancy, it's just as important to look at the ovary as it is to look at the pregnancy sac itself. So with our 3D, we're able to very quickly, in a single sweep, show that the early pregnancy is correctly located within the uterus. We can look at the uniformity of the trophoblastic response. We can look at proliferation of the decidua. But very, very important, we also look at the corpus luteum, and we look for vascular activity from the corpus luteum. So you can see that 3D is important to us, and color Doppler is very important to us in early pregnancy assessment. 3D itself has kind of given us some useful information, particularly the rendered image, the ability to do a quick 3D sweep and then very quickly produce rendered post-processing images. And for instance, first of all, if we look at the ratio between the yolk sac and the embryo, then we know that around 6 weeks they are the same. The diameter of the yolk sac, the crown rump length is the same. We know just after 6 weeks, the crown rump length is bigger. We know that before 6 weeks, the crown rump is smaller. And here you can see a highly magnified image of pregnancy sac, yolk sac, and there's our embryo. So it's a very useful way of just visually gauging the early development of a pregnancy, looking at the yolk sac, the relative size of the embryo, and looking at the trophoblastic response around the sac. The other interesting aspect that 3D has given us is, apart from better improved assessment of the early conceptors, also if we look at the crown rump length itself, we've got this thing about measurements. We've got this thing about crown rump lengths. Yet we're using the emphasis we place on crown rump lengths. We're actually using a system that is very unreliable. And it's unreliable for two reasons. First of all, we are still using a chart, and that chart was derived about 20, 30 years ago. I can tell you now, 30 years ago, we did not know what we were measuring when we looked at early pregnancy. The other interesting factor is that here's a pregnancy of around 7 weeks, just over around 7 weeks, and we can see the crown rump length there derived from conventional 2D scanning. But if we then reconstruct and get a true longitudinal axis through the embryo, you can see there's a significant difference in the crown rump length measurement. It is not always possible to get a true crown rump length measurement using 2D transvaginal scanning. And we did this study a while ago, and we looked at 100 pregnancies. They're all normally developing pregnancies, went through to term, and we all had known conception dates. We knew when ovulation occurred, and you can see that in such a large number there, where the crown rump length was smaller than our established charts said they should be. So I think we need to if we've got this obsession with measurements, then I think we just need to improve the way in which we do those measurements. And certainly 3D very quickly gives us much more accurate measurements in terms of the length of the baby embryo. And also, obviously, using 3D, we can we can rapidly, easily show anatomical variations. And here we're looking at a bicornate uterus with a heart-shaped fundus. And we can see the implantation very, very clearly, our trophoblastic response, early embryo, and yolk sac. So if 3D gives us that confidence of picking up pregnancy sacs very, very early on within the uterus, then when we get this appearance, nice corpus luteum, there's our tomographic cuts, but there's no pregnancy sac there, then we know chances are we're dealing with an ectopic pregnancy. Obviously, we don't mind using color Doppler to look at the heartbeat with a live ectopic there. And whilst we were on ectopics, and then we go on to a combination of 3D and color Doppler, it's easier to pick up live ectopics. The problem with ectopics really lies with tubal miscarriages, because these are lesions that can either resolve, or they're lesions that can slowly grow, and they grow very slowly, and therefore the symptoms aren't there that you would expect with a live ectopic. But if we look at, we're looking at this is the ovary there. You're looking at antral follicles there, corpus luteum there. Then we have this mass there, and that's tubal miscarriage. The relevance here, though, is if you look at the color Doppler, it reflects low levels of beta-HCG. So that's very useful in terms of management of that ectopic. If we take this tubal miscarriage, when you get that kind of vascularity, you know that the beta-HCG levels are going to be very, very high. And that needs urgent surgical intervention. So that's the value of color Doppler in terms of looking at ectopics, particularly tubal miscarriages. That's the case there. And you can see how the images kind of reflect what the surgeon finds. That's that tubal miscarriage, very active tubal miscarriage. There we can see those vascular, those prominent vessels around the outside of the pregnancy sac. And here with this rendered image, we can see the vascularity within the pregnancy sac. We can see peritubal vessels there. It's kind of image that we can now produce in terms of early pregnancy, including ectopics. Also, when we find something like this, we see this is a serous section scar, and this is a pregnancy associated with that scar. And again, we can see the trophoblastic action, and here's the trophoblast on our rendered image there. So this is what I'm kind of alluding to in terms of the additional information that these technological advances now give us. We haven't got time, it wasn't part of today's presentation, but obviously we talked about development of the early conceptus here, but we're also picking up more and more detail of fetal development as we approach the 10-week stage. This is a pregnancy between 9 and 10 weeks. A normal pregnancy. You can see the kind of detail that we can now pick up. This is a pregnancy at the same stage, and you can immediately see there's hygromatous changes there. There's something going on in the abdomen there that we don't understand. This was found to be an omphocele here, and increased nuchal thickness there. So we're not just looking at the early conceptus in terms of a general prognosis of a developing pregnancy, but we're getting better and better at picking up abnormalities, looking at fetal development itself in the first trimester, before 10 weeks. So the points for consideration are, as I said, there's no doubt that given the chance that advanced ultrasound technology certainly enhances our knowledge, our understanding of the reproductive cycle to include early pregnancy development. Certainly, there's no doubt it's influenced clinical managements. And certainly, it gives respect to the changes, the technological changes I described, particularly in terms of the grayscale quality, color Doppler, and 3D capability. Thank you for your attention. Thank you.